So welcome to this short video in which I'm going to explain to you the difference between chronic fatigue syndrome, often abbreviated as CFS, as a clinical syndrome and depression as a clinical syndrome. So let me give you the clinical scenario. So let's say we're in primary care and we have a, let's say, 55-year-old patient coming, and their principal complaint is, or their presenting complaint is, that they're tired all the time and that they've been feeling tired all the time for months now, maybe 6 months or so, maybe longer. And they've tried all sorts of things, changing their diets, improving their sleep schedule, getting more sleep, and it's not made any difference. And now they're coming to you because they just don't know what to do. That presentation is called chronic fatigue. Fatigue means tiredness, so the tiredness all the time, that's called fatigue. Chronic means it's been going on for a while now, months, maybe longer. So we can say now that the patient has got chronic fatigue. What we now need to do is look for physically identifiable causes of why they've got chronic fatigue. Because these syndromes that I'm talking about, both CFS and depression, they're going to be idiopathic chronic fatigue, meaning that we can't find a physically identifiable reason as to why the person has got the symptoms. As of 2024, in 300 years' time, a lot of these people that we're currently labelling up as idiopathic chronic fatigue, they might have tests that can identify a physical reason for why they've got the chronic fatigue. But as of 2024 medicine, we cannot find a cause for their chronic fatigue symptom, and then we label it as idiopathic. But obviously the meaning of this word is going to change as medicine develops, and that's understood. So basic things that the clinician will do: they'll take a history, they'll look for red flags, so they'll look for things like weight loss that might indicate that the person's got cancer, which is causing the chronic fatigue. They'll look for another red flag like bleeding from places that you're not supposed to be bleeding from, that might indicate cancer. Lumps and bumps that the person has noticed, that would be a red flag as well. So they'll look for certain red flags in the history and make sure that the person doesn't have any of those. Then they'll do a basic clinical examination, so they'll listen to the heart, the lungs, feel the abdomen for masses, see if they can find any abnormalities on clinical exam. Let's say in the history there are no red flags, in the exam there are no red flags. Then usually what they will do is they'll do blood tests as the final sort of basic screen. So they'll do a number of blood tests, for example, full blood count to make sure the person isn't anemic. They'll do renal function to make sure the kidneys are functioning okay, liver function to make sure the liver's okay, CRP to make sure they don't have some sort of inflammatory disorder, check the thyroid to make sure they don't have an underactive thyroid. Maybe they'll check B12 and folate to make sure that they're not deficient in those vitamins. They might check iron as well, ferritin, to make sure the patient isn't iron deficient. Vitamin D they might even check, because severe vitamin D deficiency is associated with chronic fatigue. So they'll do a number of blood tests, a basic MOT to look for problems. Let's say all of those blood tests come back normal. As of 2024, it is generally considered acceptable at that point, if everything's normal, to maybe now label it up as idiopathic chronic fatigue. You could go further, obviously there are a huge more tests that you can do, and sometimes when you see people admitted to hospital for chronic fatigue and they see consultants, sometimes they do end up, depending on which consultant they see obviously, sometimes if the consultant's got a lower threshold for doing tests, then they might end up with a huge number more tests done. For example, they might end up with a CT scan of their chest, abdomen and pelvis to look for any sort of signs of malignancy. But that's generally, as of 2024, not deemed necessary if they were just presenting to primary care. I don't doubt most primary care physicians or clinicians in the UK anyway would order that test if history, examination and bloods were all absolutely fine. If something came back as abnormal in any of those, if they had huge amount of weight loss, for example, then that would be an indication for maybe scanning their entire body. But generally just the presentation of tired all the time. Generally, if everything else is fine that we've already talked about it won't lead to that as of 2024. But things are changing. The threshold for CT scanning is going down, 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 down. Back in like the 1980s, the threshold was pretty much that you had to be dying, actively dying, to be able to get a CT scan. It used to be called the donut of death because people would go to the CT scan and die in the CT scan because that's how ill you had to be to actually get a CT scan back then, because they were very afraid of the radiation dose from it and what the consequences of that might be. Whereas we've now got 40 years more experience of doing CT scans, and the threshold for doing them has massively decreased, and it's just going down year on year. So it may change. It may become the case that we do have to scan people before we label up their chronic fatigue as idiopathic, but currently that's not the case. So let's, for the sake of argument, say though that the person has been scanned from top to toe and it's come back normal, no abnormality detected. So we can now reasonably confidently label the chronic fatigue up as idiopathic. So our patient has idiopathic chronic fatigue. So the question is now, are we going to put it in this clinical syndrome or this clinical syndrome, CFS versus depression? Because once you've got to this label, now the sort of split is which of these two is it? And you might say, well, that's nonsense. The difference, chronic fatigue syndrome is just someone who's tired all the time, whereas depression is someone who's absolutely miserable and suicidal. How can people get this confused? It's really obvious. But depression is more subtle than that. There are different types of depression. The famous type that everyone thinks of is severe depression, major depression, where the person is absolutely miserable, absolutely hopeless and wants to die and is actively suicidal. That everyone recognizes as depression. However, before this label of chronic fatigue syndrome existed, all of these people with chronic fatigue, when they used to present to doctors, would have been labeled up as depression, because depression also encompasses that. Mild depression is more like the chronic fatigue syndrome picture of you're tired all the time, just slightly unhappy, not happy, but not miserable, not suicidal, not hopeless. You still have hope of getting better. Our patient who's come to us with chronic fatigue, they've come to us because they still have hope that we might be able to help them. So it's not as, depression, there are these two sort of major different types. There's major depression, severe depression, which is the famous type, and then there's more mild depression, which also actually had another name. It used to be called dysthymia, dysthymia. So it's kind of the same sort of picture, tired all the time, just mildly unhappy because you have no energy to do anything. So actually, it's not so clear-cut what the difference is. So that's really the point of this video, to now tell you what is the actual difference between these two clinical syndromes. So if you've got someone with idiopathic chronic fatigue, are you going to label it up as mild depression or dysthymia, or are you going to label it up as chronic fatigue syndrome? And this is the defining distinction between them, post-exertional malaise, often called PEM. So the definition of chronic fatigue syndrome, the sort of currently clinically used definition. And actually, I should just say something. Obviously, many of you will probably have heard these sort of biological theories of what causes depression, and maybe you've heard theories of what causes chronic fatigue syndrome. The theory of what causes depression is much more famous, the serotonin theory, the monoamine hypothesis, whatever you want to call it. Very, very famous. It's in pharmacology textbooks. The public know about it. It's widely known. It is a biological theory. It is not the definition of depression. The definition of depression is not low serotonin in the brain. That is a theory that is far from being proved, and a theory that has a huge number of flaws in it. So do not take that as the definition of depression. That is a theory of what might be happening, a theory that does account for maybe why some of the antidepressants work, and that's where the theory came from. It came from the fact that the antidepressants, we think they work, and let's have a look at what they do. And that's where the theory came from. But it's a theory. It is not a clinically used definition. It is not something that has any tests that are based on it. We do not do scans looking at how much serotonin someone has in their brain to diagnose depression. So separate biological theory that is in the realm of science, that is currently under development, and what is currently clinically done, clinical medicine on the other side. And we're talking about what is clinically done, not what might be in the pipeline. So back to this post-exertional malaise then. So the defining distinction then between chronic fatigue syndrome and depression, and the reason I just went on that diatribe about biological theories is to say that, you might now say, oh, maybe the difference is the theory of what is happening. That is not the clinically used distinction between the two at all. That's why I went on that little rant. So now let's talk about the distinction and the clinically used distinction. It's post-exertional malaise. So if you've got idiopathic chronic fatigue and you get post-exertional malaise, and what does this mean? This means that if you actually get up and try and do things, like you go out and do some exercise, or you go out to the shops, or you go out and meet people, that's exertion. If you do that, it makes the fatigue worse. Malaise is kind of another word for fatigue. It's feeling awful, feeling tired. So this means after exertion, feeling really, really tired. So your symptoms get worse after you exert yourself. That is what happens in chronic fatigue syndrome. So that they have idiopathic chronic fatigue, and it gets worse if you try and get them out of bed and doing stuff. After they do go out, they might be in bed for days feeling absolutely drained, much worse than they would normally be from that exertion. In contrast, in depression, in mild depression where you have idiopathic chronic fatigue, people with this generally feel better when they actually get up and do stuff. So if they go out, even going to work, they might feel a lot better at work than they do at home, because at home they lie in bed and do nothing, whereas when they go to work, they actually do something, and the doing stuff actually makes them feel a lot better, makes them feel as they've got a lot more energy. So that's the clinical distinction between the two. If you've got idiopathic chronic fatigue and it gets better when you actually exert yourself, then we'll label that up as depression. Whereas if you've got idiopathic chronic fatigue that gets worse when you exert yourself, then that gets labeled up as chronic fatigue syndrome. And this is a key distinction, that these patients that have idiopathic chronic fatigue, they fall into these two categories of ones that get worse with exertion and ones that get better with exertion. Why is that so important? Because it's about management. If you need to be aware of this, that not all people with chronic fatigue get better when they exert themselves. Some get much, much worse. And these are the ones that have been labelled up as this. Because for a while, they tried to treat all patients with idiopathic chronic fatigue by telling them to get up and do stuff. And for some, it made it much, much worse. And those are the ones that are now labelled up as CFS rather than as mild depression. So it is important to distinguish between these two so that you know which ones to actually push to do stuff so that they'll feel better. Because people with this, actually you can make massive improvements by improving their life, by getting them out, doing stuff, by, if they haven't got a job, getting them employment, things, or helping them to get employment, things like this. Whereas people with this sort of syndrome, CFS, they're not going to benefit from that. They're going to get a lot worse if you do that. And indeed, CFS is really, really difficult to treat. Really, I would say, as of 2024, there is no treatment for it. It's a really, really sad condition. There is research going on to try and find something that might help. There are a few things that are done. People talk a lot about low-dose naltrexone. I don't know really how effective it is. But yeah, there isn't any sort of mainstream treatment that we all agree on that works really well. It's an area of ongoing research. Whereas, as I say, for the people that fall into this sort of syndrome of chronic fatigue, idiopathic chronic fatigue, where they actually feel better when they are doing stuff, then the treatment is to get them out and doing stuff. So I'll end there. Thank you very much for listening.